Thank you for joining us. I'm really excited about our subject today. First of all, just for those of you who did attend the summit, I want to thank everybody who joined and participated. I want to congratulate all the people who nominated people. That I think is work unto itself. And I really, really think the participation was remarkable. And congratulations to all the award winners. John Kanishi, who just introduced me, he won a well-deserved award. I think that gratitude is something that we can never express enough as leaders, and it's something we need to just continually do and work on. And so I'm happy to see these awards continue on an annual basis. And also Gary, congratulations to Gary for his award. So let's get on to our subject today, which is multiple sclerosis. I happened to be reading, I think it was the New England Journal, and I saw really what I thought was maybe not groundbreaking or ground shaking, but I thought it was confirming or challenging us to finally confirm that Epstein-Bar virus and multiple sclerosis were truly causally linked to each other. And as I've been trying to do since I've been here, I'm always curious, who do we have within our health system who is a nationally renowned expert that we're maybe not as aware as we should be? And all you had to do is, Google, Baylor College of Medicine and multiple sclerosis, and we have Dr. George Hutton, who is a nationally and internationally renowned expert in this space. And so we're honored to have this person as a team member, and it's important for us to know who we have on our team. So George and I met. We had a 5-minute update on that specific article, and we decided we needed a broader discussion about MS. So thank you for joining us, Dr. Hutton. Dr. Hutton received his medical degree from Vanderbilt University. He completed neurology and MS fellowships at the Baylor College of Medicine. He currently serves as the professor of neurology at the Baylor College of Medicine and the vice chair of clinical affairs and the director of the fellowship program in the Department of Neurology, and is known worldwide for his work as the director of the Maxine Messenger Multiple Sclerosis Clinic at Baylor. George, thanks for joining us and giving us, I guess, an overview and maybe a quick look at that article. So thanks for being here.
Thanks, Tom. Yeah, pleasure. And it's been nice meeting you over the last few months. I have a few disclosures, mostly related to research funding we've received or are continuing to receive for clinical trial work we do. So a brief overview of multiple sclerosis, then we'll focus on some of these facts in a bit more detail. As you're probably aware, MS is an immune-mediated neurodegenerative disease of the central nervous system, and is really responsible for significant disease burden with economic costs of up to $28 billion per year in the US alone. The classic description of multiple sclerosis is episodes of neurologic dysfunction disseminated in time and space. And that is a clinical determination, but also one that we can use MRI to support, as I'll show later in the talk. It's very common. It's the most common cause of non-traumatic neurologic disability in young adults and is considered to be an autoimmune disorder. There's about 1 million cases in the US. That's an updated number for about 3 or 4 years ago. An epidemiologic study came out. If you were at a talk maybe 4 or 5 years ago, you would have seen a number saying, 300,000, 400,000. But when we looked at it in a better, not we, but when it was looked at in a better way, actually quite more common than that. So if you do the math, that's about 1 person out of 800 in the United States. In regards to distribution, it's a worldwide distribution. You probably are familiar that it is predominant in females with a female to male ratio of 3 to 1. And the age of onset varies, but the median age of onset is 29. So the typical, description would be of a young woman, but it does affect people in other age groups and other demographics as well. In regards to genetics, there's no single gene defect found, nor do we expect to find such. There's not a inheritance pattern that would suggest, for example, autosomal recessive or dominant. However, if you look at monozygotic twin studies, the concordance rate is about 30 to 40%, which would roughly say that there's about a 30% sort of genetic determinant here. A common question we would get from a mother, for example, or from a woman with MS who is a mother, is what is the risk to my children? And we can say it's about a 4% risk in first-degree relatives, that is children, parents, siblings. So kind of a relatively low risk, but certainly higher than the general public. Now, in regards to etiology, and this will lead us into the discussion of EBV that Tom had referenced, even from a few years ago where I took this from an article, EBV had already been known for the past couple decades to be related in some way to onset of MS, but we'll present today some stronger data to support that. Other viruses have been proposed as well, less well supported perhaps, but we've always felt there could be some infectious trigger. I've already alluded to genetics. You may be familiar with those that are further from the equator having a higher risk. There is some discussion of certain toxins or trauma related to potential onset, but that's a little bit less well-founded. There's actually fairly good data about vitamin D levels, particularly those with low vitamin D levels having a higher propensity to MS. Smoking has been pretty well linked as well in terms of earlier onset, as well as those with MS who continue to smoke having worse outcomes. Obesity, particularly obesity in adolescents, has been linked. And then, of course, young adults and female sex being associated. This depiction is just trying to show that demyelination is one of the earlier changes, but over time you can have axonal loss. And what the graphic was trying to point out is that there are signs or factors that may relate to better prognosis in regards to lower risk of progression, things like earlier treatment, fewer spinal cord lesions in a younger age, whereas things that may relate to higher risk of progression would include things like spinal cord lesions being present, cortical lesions being present, delay in treatment, and older age. So like many diseases, we do feel that the earlier we treat, the better patients will do. And that brings us to talk about the recent report, which was actually in Science, titled Longitudinal Analysis Reveals High Prevalence of Epstein-Bar Virus Associated with Multiple Sclerosis. And it was primarily out of the group at Harvard, and really did make a big splash both in the scientific community, but also in the lay press, to the point that many patients were asking about it very, very early after it was first published. In quick background about Epstein-Barr virus, it is a human herpes virus that after infection persists in latent form in B lymphocytes throughout the life of the host. And as you know, it's ubiquitous, and this has been part of the problem with studying it, is that so many adults are infected that it is hard to do epidemiology studies looking at it as a risk factor because of that. And a causal role for EBV has been supported in MS pathogenesis even before this paper, in the sense that we saw increased MS risk after infection with infectious mononucleosis, elevated serum eBNAs, that's Epstein-Barr nuclear antigens in MS patients, and the presence of EBV in MS demyelinated lesions in some but not all studies. But until the time of this paper, it would still have to be said that the evidence of causality did still remain inconclusive. So it was really, as you would point out, if you think about the ubiquitous nature of the virus and the relatively uncommon incidence of MS or prevalence of MS, as they point out, you kind of need a natural experiment of some sort, some way to look at people who had been negative, who became positive, and what was their incidence of MS. And as you imagine, that would just take such a huge population because of the ubiquitous nature of this virus to find enough people. Well, some very smart people said, well, what if we look at the Department of Defense serum repository? So it turns out when people join active duty military service, they are screened at baseline with every 2 years for certain viruses, to include things like HIV. And these samples were stored. So they looked at serum samples from over 10 million active duty military personnel over a 20-year period, which equated to 62 million serum samples. And they identified within that large group of people 955 incident MS cases. Now, MS is a disease they do want to detect in the military, and it's my understanding if one is detected, they may be discharged. And so we feel pretty confident that the authors were able to look back at those cases and that those were certainly well-documented MS cases. MS cases were matched to 2 randomly selected individuals without MS, matching based on age and sex and branch of military and so forth. And ultimately, they came out with 801 cases and 1,566 controls that met those criteria and for whom there were available samples before diagnosis, and then with 2 earlier samples as well, so 3 samples before diagnosis. Those that developed MS had symptom onset a median of 10 years after the time of the first sample. And so then we have to say which of those people were negative at baseline for EBV. So at baseline, they found 35 MS cases who were EBV negative. So of the 801, 35 were negative, which again is around 5% or so, as one might expect. And they found 107 controls of that 1,600 roughly controls that were EBV negative. So this was the group they were able to look at. And they found that all but one person who ultimately developed MS had seroconverted before the MS onset. So there was one person who remained EBV negative and ultimately was diagnosed with MS, but the other 34 MS folks had seroconverted by the time of diagnosis. So the MS seroconversion rate was 97%. For those that ultimately did not have MS, the seroconversion rate was only 57%. That's shown graphically here. Time of first sample, second sample, third sample, and I didn't put in the exact p-values, but it was highly significant in this study. So ultimately, the main sort of outcome is that the hazard risk for MS, comparing EBV seroconverters versus persistently EBV negative patients, was 32.4. So a huge risk, a huge difference there for those that converted versus non-converters. Now, I don't want to go into huge detail, but they also looked at CMV seroconversion. It's another ubiquitous virus, and they did not see a pattern like this. As a matter of fact, the lines overlapped. That is, the rate of conversion to CMV was similar in those who developed MS versus those who did not develop MS. This is not just a general viral trigger. This was specific to Epstein-Bar virus. So the conclusion really is that the extremely low MS risk in EBV negative individuals suggests that by far most MS cases are caused by EBV. In that MS, they go on to posit, and we can think about this in the discussion, could potentially be prevented in a majority of people by a suitable Epstein-Barr virus vaccine. So in terms of sort of practical implications, that's probably the strongest practical implication, and we can certainly talk more about this other potential implications in the discussion here in a minute. Now, I want to just move on to some diagnostic issues. And even before I talk about this slide, I just want to stress that MS is a clinical diagnosis. People must have a clinical syndrome consistent with CNS demyelination. However, we can and often do use the MRI to support the diagnosis. And there are criteria that have been proposed and accepted for the concepts of dissemination space as shown here, as well as the concept of dissemination in time, which I'll discuss on the next slide. So they would say that there should be at least one lesion on T2 technique in at least 2 of the following 4 locations. Periventricular, which really should be right next to the ventricle. This one here is not periventricular. Hopefully you can see my arrow. Some radiologists kind of mix that up. This one is periventricular next to the ventricle. Juxtacortical or cortical shown on the far right. This is a juxtacortical lesion. Infratentorial, as would be shown here in the cerebellum, and then spinal cord, which I'm not demonstrating in the picture here. And then finally, we can use the criteria also to define dissemination in time, which simply could be that you do a follow-up MRI and a new T2 and or gadolinium-enhancing lesion is seen on follow-up, or, this is important, a simultaneous presence of asymptomatic gadolinium-enhancing and non-enhancing lesions at any time. Now, why does that count? Is because lesions only enhance for an average 3 to 4 weeks. So if you see ones that enhance and ones that don't enhance concurrently, that does already allow for that concept of dissemination in time. So I want to talk briefly about sort of this concept of the evolution of MS. And so basically there's a point in time as this sort of upward arrow represents like activity. Activity in this case is such that it exceeds this horizontal line here, sort of a theoretical clinical threshold. So basically there's a point in time that a patient has a clinical event that brings them to attention. And most commonly that might be something like an optic neuritis. And if people can't see, they tend to seek care with their doctor, right? So it is a common first symptom, at least, that brings people to attention. And in our parlance, that is called a clinically isolated syndrome. And what that implies is a first episode of what looks like MS, but you don't have that second episode that classically, which is what this arrow is pointing, would be defined, MS would be defined as a second clinical episode. By an older criteria, that would be called clinically definite MS. But nowadays we can say, well, but look at, there's new lesions, which is what these yellow dots represent, and we can call it MS based on what I refer to as the McDonald criteria, based on that concept of change in time and space as defined by MRI. And indeed, that can happen even at the time of clinically isolated syndrome if that MRI meets both time and space criteria. But another important concept I want to point out from this slide is that, and this is, of course, just a depiction, but we see this clinically certainly, is that at the time of first presentation, we will see a number of lesions on the MRI in many patients that were probably and highly likely to be asymptomatic since they didn't bring the patient to clinical attention. And so there is this period of time where lesions are happening despite not having clinical symptoms. And in fact, we sometimes find those people. So those are people who have a headache and they go somewhere and someone does an MRI, or they have depression, or they're perfectly normal medical student. We put in a scanner to do a control. And for whatever reason, we find lesions that conform to the diagnostic criteria for MS. And that actually is called radiographically isolated syndrome. And by the way, over 10 years, 50% of those people will develop MS. And so it's an interesting concept. You've got this preclinical phase, you've got the phase where they actually come to clinical attention. And over time, as you're probably aware, those with relapses that show some improvement, we call relapse or remitting, can indeed develop secondary progressive MS. And so again, I've said most of this. The MRI studies reveal that the early course of MS is primarily subclinical. And in regards to natural history, I'm going to talk about treatments now in a minute, but untreated MS, 50% of patients with relapsing disease will develop secondary progressive MS within 10 years. And if you follow those patients long enough, ultimately 90% of patients will develop secondary progressive. Now, again, we are impacting that with our current therapies, but those are the historical numbers. So how do we treat MS? Well, we're going to talk briefly about disease-modifying treatments. That's the mainstay of our immunotherapy. We also have to manage relapses less commonly now than earlier in my career because we are doing better at preventing those. But the mainstay there is steroids or, if unresponsive, plasmapheresis. We do a lot of symptomatic management day to day in clinic. This is what I do all day long, is manage symptoms. And then, of course, don't overlook non-pharmacologic treatments like physical therapy, speech therapy, counseling, whatever it may be. This slide just allows us to reflect back that, there's been great development in the field of MS in terms of therapeutic development. So the first drug came out now almost 30 years ago, an interferon product in 1993. A couple other interferons came out in that early era. Green on the slide depicting injections, things you inject yourself with. The other early drug was glatiramer acetate. We still use these drugs mostly in what I refer to as the legacy patients, that is people who are on them and doing well. Couple infusion therapies came out early we no longer use. This one listed here, mitoxantrone, but natalizumab is still in broad use, came out in 2006. And then a few others more recently, including ocrelizumab, which is a B-cell suppressor. And then 2010 and on was sort of the era of oral therapies. And there's been sort of about 9 or so total there. And then one more injectable therapy, which is also B-cell therapy, came out fairly recently. So very briefly, how do these drugs work? Well, most of them work in various peripheral mechanisms working on really affecting cytokine production. But I just want to point out a few in particular because they are fairly broadly used. And ocrelizumab is a B-cell suppressor, and this is just trying to show here a blood vessel with a circulating B-cell, which is again represented here, showing you that ocrelizumab is a monoclonal antibody specifically targeted to a marker, happens to be CD20, on the surface of B-cells, and so it does suppress B-cells. That may have some implications in regards to this concept of EBV that we mentioned, so I'd like to maybe discuss that a bit more in the discussion. Natalizumab has another unique action with our first monoclonal antibody for MS care. It works specifically by blocking a molecule that's important for transmigration of an inflammatory cell from the blood into the brain. So basically, it shores up this concept of sort of increasing or decreasing permeability of the blood-brain barrier. So less cells get in, less inflammation, better outcomes. So we now have about 20 disease-modifying therapies that are approved. They vary in terms of mechanism of action, efficacy, safety, tolerability. And there's still no standard treatment algorithm or means of predicting which one will work best for a given individual. Sort of the holy grail would be predictive studies that one can do to look at biomarkers, for a better response. And it's still the case that people may have continued disease activity despite treatment with our available medications. And so what are the goals, or at least is what is looked at in clinical trials? Reduction of relapses and the corollary of extending the time between relapses, reducing the severity of relapses. Studies will often look at the prevention or extending time to disability milestones using certain measures as listed here, preventing or extending the time to onset of secondary progressive MS. And at least in trials, these last two would be secondary outcomes, but still very important in clinical care, which is to prevent or reduce the number and size of new or enhancing lesions, and really, as a corollary, to limit the overall MS disease burden in the central nervous system. So how do we choose a disease-modifying therapy? Which one is best? There are theories of perhaps you should go to the strongest drugs first versus theories about escalation, which I'll talk about at the very end. Some would believe in immune reconstitution therapies, which are these strong therapies that you give for a period. So alemtuzumab is given as a yearly cycle ×2, and then you stop it, and it should help for a number of years, versus a more traditional approach of continuous therapy over time. Some would kind of focus on mode of administration. Patients in particular, I want an oral therapy perhaps. And then some would focus on mechanism of action, with many proponents of B-cell suppression in our field. So very briefly at the end, I just want to point out this ongoing debate about initial high efficacy therapy. And so proponents of a high efficacy approach would say that the disease can be quite bad. There are people who have significant brain atrophy. Let's be as aggressive as possible, and that may lead to less disability and less brain atrophy long term, versus proponents of an escalation therapy approach, which would say, let's use safer, more established treatments, and then we can always escalate to higher efficacy drugs if this one is inadequate. Historically, the latter has happened just because we didn't have high efficacy drugs till recently, right? So if someone was diagnosed 20 years ago, they by nature went through an escalation therapy approach, versus now when we have these drugs available, that's the debate. Do we start a newly diagnosed patient on high efficacy? And I just do want to point out that we are involved in the Deliver MS trial, which is one of two international ongoing trials looking at the concept of taking newly diagnosed patients, randomizing them to high efficacy versus, quote, escalation therapy approach. The trials differ a little bit in their definition of high efficacy. In Deliver MS, we include basically all the approved monoclonal antibodies and a commonly used but not approved one, which is rituximab, whereas everything else falls into escalation. The corresponding trial, Treat MS, includes cladribine in high efficacy. And these are both ongoing, and hopefully in the next few years, we ultimately have an answer to this ongoing question. And with that, I think we'll move into the discussion. I certainly appreciate everyone's attention this morning and look forward to the discussion.
I have a couple. One is the incidence of MS going up, down, or stable?
It's a good question. I think likely the answer is it's going up a little bit. I think all of us treating MS felt that 300,000 number was inaccurate, just because you go to a conference, I have 4,000 patients, this guy has 4,000 patients, you start adding up in your head, it just didn't make sense. And so I think there was this gut feeling there must be more cases, and I think it was just a more careful analysis that allowed us to see the greater prevalence than was expected, or than had been traditionally looked at. I think there's a bit of better recognition concepts as well, in our newer criteria being more sensitive in allowing earlier diagnosis, and particularly in sort of third world countries and countries where we don't have great access to, say, MRI. I do think partly as that has improved throughout the world, in some of those countries, we are just seeing better numbers, partly, I think, because of recognition. So I think there's a number of factors, but overall, I think the numbers are going up, yes.
And Tom, I don't know if you had a question. I have a couple more, but go ahead.
No, I mean, I guess it was a little bit of a dovetail on that. I think, as I look at MS, I think about, the first thing I say as a general internist and, on attending wards or something, and when somebody says a patient is admitted with MS, I'm always like, well, are you sure? Because people get labeled with MS and, they carry that diagnosis. And to me, obviously the therapeutic interventions are important and they're constantly evolving and we've made some progress, but it's always been such a difficult thing to make sure someone has MS, right? And I think as we do more and more imaging and we lean more on the imaging and less on the clinical diagnostics, I was wondering, are we labeling people more with MS because of all those images that we're doing for the routine headache, inappropriate CAT scan that get orders all over the country now? Did that play into that? And I guess, is it okay to make a preclinical diagnosis? Is there advantageous therapeutic interventions? I mean, to me, the ideal would be preclinical diagnosis, do something to prevent it from becoming clinical. To me, that would be like, is that how your mind thinks? So two things. Are we picking up more on MRIs and inappropriate, I'll call them inappropriate because that's what I think, headache, scans. And two, would it be a goal actually eventually to get preclinical MS diagnosed to do something before it becomes clinical?
Yeah. I do think there is some misdiagnosis out there, right? Overdiagnosis, as you would say. And it's hard to stop that. I mean, because we can't sort of re-educate the entire, neurologic universe, right? But people do over-rely on the MRI. There are particularly, these sort of non-specific white matter changes that many adults have related to cardiovascular disease, perhaps related to migraine headaches can actually, lead to some white matter changes. There are a number of papers written on that where, big MS center might, look at their intake of possible MS.
Right. How many people sent with the diagnosis of MS and then turned down, yeah.
Right. And some of those series will be as high as, 30% of misdiagnosis. And there was one great paper a few years ago, I wish I could remember the reference, of kind of more of a philosophical approach to undiagnosing MS and just the clinical and sort of societal and social implications of that. People get very attached to the diagnosis. It becomes a bit of an identity to them.
Yeah, I've had a case or two like this, and it was very difficult to tell them they don't have MS.
It's very hard. It's very hard. And when we do it, I honestly don't know if they just go back to their other doctor and continue treatment or not, because they often do not follow with us in such a setting. So I don't know what happens with those folks. Now, regarding, I think if I understood your second question was kind of like, the value of early diagnosis and what does that, could we even look at in a preclinical?
Well, you think about rheumatology where you do the DMARDs early on before you have any damage and you prevent demyelination ahead of time, so you're going upstream to reduce the severity of illness before they even get clinical.
Yeah, I mean, the data we best have on that is a couple things. Number one, a number of the drugs, at least in the 2010 range, were doing studies in clinically isolated syndromes. So people who technically didn't yet have MS but had the first episode with an abnormal MRI. And to be fair, on newer criteria, some of them might qualify as MS.
Right.
At the time, what was being called, high-risk clinically isolated syndrome. And indeed, one of the interferons had good data there, teriflunomide had good data there. So a number of drugs would show that you did decrease the rate of progression to a clinically definite MS. And then there's trials that looked at, back at their placebo group. So one of the interferon drugs comes to mind, I'll just name it Rebif because there's so many of them, that in their 2-year placebo-controlled trial, and then they followed patients an additional 2 years, the patients who were initially on placebo never did quite as well in the long term in terms of disability as those who were on, at that time, 4 years of continuous therapy. So that even a 2-year delay in early MS led to a worse outcome.
Right.
So I think we've got good data that says the earlier we treat, the better. There are studies looking at treatment of radiographically isolated syndrome that I described. People who, it's not the syndrome you and I are thinking about where we talk about someone with headache getting, sort of non-specific findings, but people whose MRI actually conforms to those criteria radiographically, but who don't have a clinical syndrome, so we don't call it MS. And there are some treatment trials there, so we'll see what that shows. I'm still a little bit myself leery of that concept where, you'd say only 50%, if you want to say it that way, develop MS within 10 years. It means 50% don't, and yet you're treating them with a therapy that they don't need maybe in that case then. So it's, that's a little bit unclear how early you really want to start therapy in that case.
Right. I know, Ankita, you have a question and there's some chat going on there. Are you going to do some traffic control or somebody?
I am, yes.
Yep.
So we have a question from the audience, and it was similar to my question. When we start thinking about EBV, in MS, we also go to other autoimmune diseases. And like, how do we judiciously use EBV? Because EBV titers are checked a lot in a lot of different illnesses. And the second question was, should we be considering other autoimmune diseases when we correlate to EBV?
Yeah, so I'm going to express a little ignorance on the second one because honestly, I don't know the data for the other autoimmune diseases, but I'm aware of the concept that they've looked at it. I just don't have fresh data in my head for that in that regard. It's a good question, right? So I do see people checking, EBV titers, and I always wonder to what end, right? It's again such a ubiquitous virus. I don't think, in my mind, that this paper we reviewed from Science would suggest anything different I need to do or you all need to do in regards to my MS patients in terms of using EBV testing in a current MS patient or as a predictive test for someone you think may have MS. Because again, it's such a ubiquitous virus in a single individual. I don't think specific testing is going to help us. Now, I will say there are some ongoing trials. For example, there's a trial in progressive MS. The drug doesn't have a name yet, just like an ATA, something, drug company number, looking at use of it. I think it's a T-cell directed anti-EBV product in trying to help progressive MS. So at least the theory's out there about, is there some role of treating some element of EBV to help people with MS? And I think, that's probably less likely than the benefit of a potential vaccine in prevention, because it might be a sort of a horses out of the barn concept by the time you already have MS. But at least the concepts are out there about that potential role.
Any other questions in there we have?
Just, did you want to come back, George? You mentioned, I'm not going to pronounce this right, the ocrelizumab and T cells. Did you want to come back to that?
Yeah, the paper points out, and I've seen a few commentaries that at least, propose this as well, that, maybe part of the benefit of ocrelizumab, and we have another product called ofatumumab, which are both basically targeted at B cells, just two different, mechanisms specifically, but they're both B cell suppressors. Maybe that's partly where their benefit may be seen, right? Is by eliminating EBV, secondarily because EBV is resident in the B cells. No one's proven that, but that's part of its mechanism, but that was posited, and I think it's a reasonable thought process. There's a third B cell therapy that's very close to approval, and a lot of people are using rituximab off-label, so we kind of soon to be available. And maybe that's part of its role. Who knows? Either way, it works. But at least at the sort of basic science level, something people can look into some more.
Well, I think maybe we should wrap it up. I think we're at just about 40 minutes, Gary, unless you have any other.
No, I think that's great.
Any more questions? George, thank you for joining us. I think it's just, first of all, it's nice to meet you and have you. We consider you part of the family of CommonSpirit, and we really appreciate your thought leadership in this space. And you'll be hearing more from us. And thanks for joining us.
Thank you.